job that was, giving us more insight and helping us to understand that relationship between cannabis, psychedelics, and other forms of integrative medicine. We're going to continue that conversation moving forward. I'm bringing in another expert to share their expertise. Next, I'll be calling to the stage Dr. Maysa Alavi. Dr. Alavi is a physician leader in cannabinoid and psychedelic medicine. Dr. Alavi is a rare bird in that she has worked in all three facets of the psychedelic ecosystem, from the clinical practice to site investigator research and sponsor-level drug development. She's a graduate of the University of Texas Health Science Center at Houston and has completed residencies at Harvard UCLA, USC California Hospital, and the University of Arizona. Dr. Alavi served as an investigator and study therapist in the MAPS Lykos Phase 3 MDMA trials and Compass Pathways Phase 2B psilocybin study, and holds a certificate in MDMA-assisted therapies from MAPS. She's the founder and chief medical officer of the Center for Functional Psychedelic Medicine in New Orleans, where she unites individuals and group ketamine therapies, giving cannabis education and other forms of functional medicine education. She's also previously directed clinical methodology and safety for the 5-methoxy-DMT and psilocybin drug development programs. Of course, she'll be using all of that to share with us on the topic of cannabis as a psychedelic, functional pathways for healing, integration, and nervous system regulation and resilience. Please help me in welcoming our next presenter, Dr. Maysa Alavi.
Good morning. Thank you so much to the SCC for having me and for your attendance and making this possible. I'm very excited to be speaking. I just wanted to take a moment to notice how we felt when Robin was speaking. I felt relaxed and just very peaceful listening to his voice. And today I'm going to be talking about what that is. What are we picking up on there? And what is this concept of how we can wire and fire together? So the objectives for today, I'm going to explain the basic structure and function of the ANS, or autonomic nervous system, and the importance of the vagus nerve in the system. We'll look at what nervous system health really means, ways to define it and measure it. We'll talk about key principles of polyvagal theory. My hope is that this talk is really applicable to your clinical practice, and I believe this is a great model to explain what's happening and what we can describe in that interaction we just felt. We'll differentiate how cannabis, entheogens, and classical psychedelics interact with the nervous system, and I'll give you a great slide for where you might want to start a client or how to educate someone on which might be the best psychedelic of choice and what would it look like for your nervous system to handle that well. We're going to apply some practical tools for assessing this. So there's a lot of information on my slides. Just think of them as a resource. I'll make them available afterwards. But really just try and take in the information and take photos where you need to. So we're going to do a case study. I have permission from the client to talk about this de-identified case. This is a client of mine who's a 38-year-old non-binary client, past medical history of MDD, so major depressive disorder, treatment-resistant as medically defined, general anxiety disorder, concussion, 4 years prior with loss of consciousness, that's significant. Complex trauma related to, as he says, and there's issues around gender identity and growing up in a home of alcoholic parents, suspected PTSD, and celiac disease. And I bold that because the immune system is related to what we'll be talking to today. It's a sign and symptom that he has celiac. So our clinical team here, he has a therapist already. He's doing internal family systems and CBT. He has a PCP and a psychiatric nurse practitioner. He's on lamotrigine 25 milligrams BID, and he uses regular cannabis to function. He failed Lexapro, Wellbutrin, Trintellix. This would make him treatment resistant, as it were. The psychometrics we collected are below, and the summary is that this client has severe depression with active suicidal ideation. Important to have a game plan for safety when that comes up. They have possible alcohol use disorder, moderate anxiety, probable PTSD, and definitely low mood. So where would you go with this client? And how would you feel in the room with this client? The vital signs, I just want to note the blood pressure, so just keep that in mind. He had restricted breathing, flat affect, depressed mood. You'll notice that the voice doesn't carry, it's not melodic, it's usually monotonous. So important things to pick up, there's poor eye contact, and the client has also had decreased facial expressions. He describes himself as an atheist who doesn't believe that life has any significant meaning. It's important to ask about that. Social connections, though, appear to be significant. Friends and a very strong mental health team. And the clinician has the thought that, and I phrase it that way because this is a technique we bring into our practice with psychotherapeutics of nonviolent communication. So it would be a judgment to say that he is logical and disconnected, but I have the thought that he's living in a very logical, left-brained world, and he feels disconnected from himself and probably people around him and the magic of life. I note my own restricted breathing in this interaction. I don't feel relaxed, I feel more tense and closed off, less connection, maybe a little uncomfortable. I would call it a difficult client, right? They're not coming in like, everything's working, things are great. This is a pretty heavy intake appointment. And with the help of ChatGPT, this is what he might look like. I'm really into GPT prompting. After being medical director at USONA, that's one thing I really took away was the use of AI and its utility in drug development and other processes. So I prompted at first for somebody, and the photo, my partner and I looked at it, was like, he looks like really stressed out in this photo, and maybe we can make him a little more attractive. So I prompted for an attractive male who's got these symptoms, flat affect. I put all of the clinical findings on exam in there. This is what we got, I like it. And I apologize, the formatting wasn't so great. I'm a PowerPoint keynote person, so I use Mac. So let's look at the nervous system. What does it mean? Basically think of nervous system as CNS plus the brain and spinal cord. CNS plus brain and spinal cord. So really simple there. The peripheral nervous system we'll talk about. That's what's going to connect the brain to the rest of the body, or the central nervous system to the rest of the body. It's going to connect with our glands, our organs. And then within the PNS we have a somatic system that's going to control the muscles, and the autonomic nervous system, which controls all the involuntary actions. So looking at my clients' pupillary responses, looking at their blood pressure, and getting some insight into those involuntary, as well as the heart rate, the breathing, and here we have digestion and regulation of emotion being controlled as well. So a very significant branch. And for the longest time we thought, okay, it's fight or flight, or it's rest and digest. Those are the two main functions. But we'll see that historically this has evolved to include a gut brain that controls your digestion. Very important to know about your client's digestion and their regularity and bowel health. And not only that, but polyvagal theory took it one step further and said, no, actually these branches, there's two extra ones. There's a ventral branch and a dorsal branch. And that's actually verified in neuroscience, so looking at the vagus nerve. So we're going to divide that branch of the parasympathetic into an additional branch, a couple branches here. So here's the historical evolution, and I note this here because I graduated med school at Texas Medical Center, and one of the foremost areas of education and research, and I only ever learned about that first row. Right? So just fight or flight and rest and digest. But the gut brain never came up in my medical education. So it's important that we really talk about this, especially with our clients. And not only that, but 1990s to present, we've had polyvagal refinement. So the parasympathetic nervous system is now being branched into ventral and dorsal vagal branches with the work and the help of Porges. So let's look at that a little bit more. But first, using ChatGPT to make a really nice outline here. It had a very hard time making a beautiful infographic that was accurate, but this was very clean. And a picture of that entire nervous system anatomically dissected is very difficult to do that dissection. So is cannabis a psychedelic? Well, Robin did a really great job of talking about this, so my job got a little easier, but why does it matter, right? And I think it just gives us a common ground, a linguistic basis on which to talk about these medicines. And it's a fun topic for a lecture, it's a great topic for a debate or a discussion, but if yes, you put your cards on the table, cannabis most definitely has psychedelic properties, while it would not be defined as a classical psychedelic, and that's the conclusion here. But most importantly here, it's giving me a sense for if my client has used cannabis, might they be able to handle non-ordinary states, and to what extent? And that doesn't depend on their experience of cannabis and the depth that they've taken it to. And moreover, we can increase the conceptual field of psychedelic medicine. And I think that's important because we are on the brink of something really incredible happening. And I'm envisioning that there'll be educational programs and proper degree programs where individuals really focus on this way of increasing neuroplasticity and using these novel markers to provide a new path that's different from what current medical psychiatry is. Okay, so here are the two widely accepted definitions. We have an etymological, looking at the definition of the word as historically defined, and then we have pharmacological, defining it as a 5-HT2A receptor agonist. So the etymological view, I think we can probably all agree that cannabis, in fact, can be a very powerful psychedelic. And so here are the ways in which it alters our perceptions, right? It can reveal or amplify our thoughts, alter perceptions of time. It can produce illusions or straight up hallucinations like closed-eyed visuals. And, occasionally introduces a lot of states that can be typical of, trips where there's depersonalization, derealization, and mystical states. And not only that, important to note that cannabis can be linked to what's called cannabis-induced psychosis. And similarly, psychedelics can also take one of, predisposed background into a state that might be quite traumatic for the client. So the pharmacological view, well, there's some supportive findings, namely that high THC cannabis can elicit these psychedelic-like effects that are quite strong. What would be its signature? I'm very curious, and maybe that's the next question. What are some of the defining features of that cannabis-induced psychedelic experience? So we do have some indirect modulation of 5-HT2A, or a possibility for it, but we don't have very many controlled studies, and we are primarily stimulating the CD1 receptor with the THC to create these experiences. So I would say that cannabis is psychedelic adjacent by the pharmacological view, and we can call it a non-classical psychedelic. So here's a novel graphic that I created with the help of ChatGPT to look at cannabis on a psychedelic continuum, where on the vertical axis is the intensity of the experience, peak being DMT, LSD, and on the level of serotonergic involvement, noticing that that peak intensity is related to the serotonergic involvement, and again, when those receptors are blocked, the trip doesn't occur. So here's the continuum and the ways that we would describe the very categories, as well as examples, mechanisms, and typical intensities, and then some characteristic psychedelic qualities. Again, Robin touched on some of these, ketamine being the dissociative aspect, MDMA being the prosocial or entheogenic aspect. So let's get into the polyvagal theory. We're breaking down that parasympathetic system now into these two new routes. So these are actually states that are cued by access to a subconscious and a conscious response to safety or threat. So it's interesting to note this concept of neuroception. These may be seen or unseen threats. They may be picked up as we are in a room with somebody, right? Is that what I'm picking up on when I sense the tenseness in my client? And even proper threats to life, danger, safety that are obvious certainly will contribute to the adaptation or the modulation of this nervous system branch. Let's talk about the vagus nerve. These are the two branches that are now being introduced through polyvagal theory. This is the wandering nerve. It's actually the 10th cranial nerve, so it begins in the central nervous system in the brain, and it is the longest nerve. And I had a really beautiful picture, I think maybe it's on the next slide, but it'll show this nerve literally wandering. And it's bidirectional. Primarily, it's going body to brain and not top-down, brain to body. So that's very interesting. And in its path, it's doing a lot of intertwining in the intestinal system, as I mentioned, the gut-brain being a concept here. So we're having this rest and digest and connected circuit, all connected, yes it is, through the vagus nerve. Just love that picture. Innervating the heart, the lungs. So we have two branches, the ventral vagal complex and the dorsal vagal complex. For the theory and for the remainder of this talk, we'll likely refer to this as dorsal and ventral. So the origin of those complexes, the ventral vagal complex begins in the myelinated vagus nerve. Myelinated meaning it has a fatty sheath, think of an electrical wire, and that's the insulating sheath around it. And the unmyelinated vagus doesn't have that sheath. So that's going to be called the dorsomotor vagus. And here we have the breakdowns of what the functions are. So the ventral vagal being more social engagement, calmness, connection, creating the concepts of heart and lung coordination and various tone in the voice. And the behavioral state associated with the stimulation there is one of relaxed safety and connection. Whereas the dorsal vagal, we're mediating immobilization, freeze, and shutdown processes. So when a client is in a state of freeze, collapse, or conservation, and we'll see that conservation has a lot of physiologic symptoms as well. Just know that more of one doesn't always mean better. It's a balance between the two, as most things, homeostasis. Okay, so there's a lot of good empirical support, and these pathways are anatomically proven, and there's a lot of connection between higher cardiac vagal tone to empathy and theory of mind, which means the ability to put yourself in someone else's shoes, essentially. Cardiac vagal tone is related to heart rate variability, and that it can be a measure of this nervous system balance, and we'll talk more about that. Oh my gosh, I'm so sorry. When I reviewed the slides in my PDF, everything looked great, but this is like the crux of it. It's a very important picture, but luckily I broke it down into smaller segments. So this is the ventral vagal state, and I want to just bring attention to what's happening and the increase of physiologic function. So we'll see with this state, when a client's in the ventral vagal, they'll feel less defensive, and they'll have improved digestion, improved intestinal motility. They'll have a strong immune system with resistance to infection. They'll feel more vital. There'll be increased oxytocin, creating more connection, and they'll have an ability to relate and connect with you and other people. We'll see increased movement in the head and the eyes, more head turning, more prosody in the voice, and a more relaxed breath. Things you might notice emotionally is that they're compassionate, they're calm when they're connected, and more curious and open. This person you would describe as settled, grounded, mindful, and in the present moment. And as I'm saying those things, I'm trying to get there. I can feel my sympathetic system with the situation with the slides, and I'm entering some fight or flight. I'm in the sympathetic state a little bit. So what does that look like? So panic, fear, anxiety, worry, concern, am I being judged? Oh my gosh, this seems so unprofessional. You know, luckily there's no rage, it hasn't escalated. Right? But the goal is that I can adapt back and forth. So now I'm like bringing attention to it, and it kind of diffuses the situation. That's a great technique. NVC does that a lot, nonviolent communication. So I'm feeling nervous because I need more predictability. I practiced for this. So my request would then be, would you be willing to bear with me and have fun and laugh? And they're fun, that's beautiful. So that was an example of using NVC. So here in this state, my blood pressure went up. I noticed my heart rate increases. I got flushed. I had more fuel available, so like nervousness, you might talk faster, all of that. Adrenaline, there's more circulation to my vital organs. Not a great way to improve circulation overall in ongoing, but it happens, and my pupil size probably increased. I probably had some more dilation of my bronchi, maybe to get me to breathe more slowly, and you could get defensive. Notice here your insulin activity decreases. That's why cortisol can be a really good measure to do in your practice. I recommend diurnal, and we'll talk about that in the functional side of what I do. Your digestion will decrease. Early sign or symptom, you've got to ask about how their digestion is. Your relational ability will decrease. You have to really catch yourself not to let it snowball. And the immune response. So what's going to happen there is maybe early autoimmune, just, I'm sick all the time, I've got allergies, I hear that a lot. Gut is related. Okay, I did not go to shutdown or collapse, but that's where my client was when he came in. And so here we have a lot of things that we saw in exam: dissociation, maybe feeling suicidal as he was, shame, depression, hopelessness, feeling trapped, even checked out, just going through the motions. How many times have you heard that? Just going through the motions. So here we have increased fuel storage and insulin activity. We don't know if we're our body's shutting down, we're gonna hibernate or what. So look for their body habitus, check a BMI. Are they being more immobilized in behavior because of fear? There's going to be a pain threshold that raises. Could this explain cutting? Right? I need to feel again. Wow, the average thing doesn't work. Just like shaking my body or slapping myself around isn't cutting it. Sorry for that. Decreases in your heart rate, blood pressure, temperature. His blood pressure, it wasn't bad, 116/70s, but You know, you get those adrenal fatigue patients and they're just barely keeping 100 over 50, 40. But it wasn't as high as it could be for a young, healthy male. So we'll see, that's actually gonna change in our course of therapy with them. It's pretty amazing. Depth of breath, social behavior, attunement to the human voice, right? Some of these patients, I never get a looks dead on, and I'll talk and say something and it doesn't really necessarily seem to register. So it's important to see how they respond to voice. So here's a similar diagram. It's not exactly the same. The nuances of this diagram I don't like as much as the other one. But what I do like about this is it's showing this fluctuation. So the nervous system health is going to look at how easily are you going from ventral vagal or socially engaged to sympathetic state and back. And in the moment, that's called regulation. And over time, it's called resilience, and we can measure that. Okay, here's the nervous system, a continuum. I think you get the idea of what this is presenting, but going from gentle to more intense, and what psychedelics can do to the nervous system state as we're looking through the polyvagal lens. So here we have the various states and the general guidance for psychedelic use, broadly speaking psychedelics, anything that's mind manifesting that could create, harm in effect. We're getting someone back to a more neuroplastic state. Let's make sure that we're using proper guidance and that we have an aim, and what we're trying to do is, in the case of getting someone out of a free state, to just gently reawaken them, gently help them feel safe in their body. So the rule and the name of the game here is start low and go slow. And I'm sure you've heard that with cannabis therapy. We're going to use body reconnecting agents like cannabis, low-dose ketamine, MDMA, and we'll emphasize a very warm, rhythmic, and safe approach. Very important to get proper training in space holding and psychedelic-assisted support for this reason. The things that you say and do in that space for someone who's been frozen for a long time make a big impact on whether they start to thaw or not. Okay, your client's in a sympathetic state. We want to use some calming and pathogenic compounds. Here, CBD could be very useful, MDMA and ketamine, but at moderate doses. And the pacing should be careful. I always use objective measures and subjective measures to provide guidance on how to continue the ketamine dosing and how to reassess whether we should increase, stay the same, go down. And the aim is to settle that excess energy. Here we're more hyper-aroused, so we want to downshift and think of a car just literally doing that. We're going to downshift to a more grounded and less defensive state. Your client's already in ventral vagal. Your treatment worked. Now what? Oh, this is the client that comes in, I'm doing really well in my psychotherapy. I want to explore myself some more. What can I learn? Where can I go? My kids are out of the house. I get a lot of this women in their, middle age, and their children are gone, their career's kind of winding down. I'm taking care of everyone else. Now it's time to take care of myself. And I'm kind of wondering why I haven't gotten over this one thing, right? If you're that woman, please seek us out. You're our primary client. We love working with that woman. She's responsible. She's already in therapy. She has been taking care of everyone else. So let's acknowledge all the mothers in the room here, all the women, all the really feminine, of course, that are holding it together for a lot of us and doing it without necessarily getting that acknowledgement that they might be needing on that needs model. So, what do we do for them? Of course, look, I'm almost overlooking myself and all these women. So we want to optimize safety, right? We want to optimize this relational setting so they can go deeper in their work. This is where you might bring in some potentiators, some amplifiers, breath work, music, movement, more embodiment and connection, connecting with the ancestral roots of our medicines. This would be a beautiful opportunity to connect with that as it was brought up in yesterday's talks. So here, we want to help these individuals integrate, right? This is the measure of the success of these treatments. We want to deepen their regulation and their insight. Okay, this is the slide you've been waiting for. Okay, let's walk through it briefly. Each of these medicines has what I would consider an optimal dose and route, and the effect from the different states. So I'm going to just work with when you're frozen and when you're activated, when the client's been there for a long time or predominates there. That's what we're looking at. So there's some doses of cannabis, starting with the low THC when you're frozen and moving it up a bit when activated. But remember, high THC can fragment and disembody even more. So you're going to aim for an introceptive state and just dose it as needed to create that state. And I recommend, with inhaled doses, waiting 20 minutes between doses if you do increase. And especially important if your client's already coming in anxious and very dysregulated in the moment too. For MDMA, we'll start with a little bit lower dose when frozen and a bit higher when activated. And I recommend some booster doses based on research. And again, what might be hopeful if you're educating somebody, right? This is a presentation for educational purposes. So in a frozen state, we want to just promote some gentle reconnection and safety. And this is oxytocin is going to be helping us do this. And when activated, we want to reduce the fear and foster more openness, empathy, and trust. That's why methods like NVC, where empathy is the language of connection and love, are very important to understand and have a good, strong grasp on. So this is an ideal therapy for attachment trauma. We saw that with the research that MAPS performed, and my firsthand experiences working with the medicine. I've seen some incredible outcomes. And it does also require work by the client. This is not an easy task to take this medicine and work through it. So again, important to have proper support for this repair process. With psilocybin, some recommended dry fungi doses as well as the psilocybin equivalent. Now remember, this medicine, with the cathartic state that it can induce, it's important to know that the freeze can intensify actually before it releases and emotional thawing takes place. In the case of someone already activated, can really bring them into the activation of fear processing, and then ideally lead to some surrender and solution with insight. So a very important safe container here is necessary, especially as the client goes through this activation valley, as we call it. With ketamine, weight-based dosing. Easy, I love it. The experience intravenous can be as long as you need it to, injectable, 45 minutes to an hour. You can give a booster dose easily. I love that ketamine is also legal and can be utilized now, and I think it's being underutilized. So I just want to put in a plug for exploring ketamine as a pathway for increasing BDNF, brain-derived neurotrophic growth factor, which is what's thought to be the basis of all this plasticity, having rapid antidepressant effects, being accessible, being inexpensive, constantly encouraging my former colleagues in the ER, as I used to work in emergency medicine, to use it as a first-line medicine for pain, depression. It does not tank the blood pressure if someone's in septic shock. We don't need to rely on fentanyl anymore, propofol rather, in the ER for acute sepsis management. Yeah. And it will save our payers money, it will save our insurance companies money. It's really quite a miracle medicine, one of the top 5 most important medicines by the WHO. Huge advocate for that. It allows us to do surgery in austere environments. It does not require the constant monitoring. It's a wonderful medicine for reducing fractures or dislocations in children. I've seen it used in so many environments. I can't speak highly enough about the importance of this medicine and the importance of setting the stage in those critical environments. Telling the child, okay, go to a nice restful place, because you're really setting a dreamlike state in this dissociative state. So when you're frozen, it's going to suspend that freeze. I didn't say bypass, I said it's going to halt it, like turning it on and off again. Your nervous system deserves that. It deserves to have, rewiring upgrades, as well as when it's glitching, turn it off and on, like any electronic complex computer. In a case where it's activated, the client's activated, we're going to soften defenses and expand perception and self-compassion. It's excellent for stubborn freeze states. And 5-MeO-DMT, I'll just leave with very important that your client's highly prepared and well integrated already. It can be very destabilizing because it's going to create a break from that reality of freeze or sympathetic immediately, and it could be intense for those who have release ego. So what's nervous system health? We have regulation, resilience, and connection. Remember, regulation is moment to moment. Resilience is the adaptability to that moment to moment stress over time. And the connection is a very important measure as well. So is somebody regulated or not? These are ways to tell. Tenseness, numbness, nervous system health. So looking for the things that I looked for in my client, I could have added heart rate variability through a heart map device or other device we'll talk about. I could have measured the cortisol value. I usually prefer to do that if the client's willing, and their skin conduction as well. So our nervous system states, here's some more subjective measures. The last slide was objective. The psychometric testing we typically do, we use an app called Osmind. That's our EMR, and it will ping the patient when it's time to do these. We get them before every ketamine and after every ketamine with a good frequency. Then my observations and self-reflections are important, and then there's a client report, which is really critical. These patient-reported shifts are some of the most important to be tracking. I like to ask regularly, do you feel more socially connected or isolated? Here's some examples of questions you can ask in your practice, and just know that when they're increasing their social engagement, They're returning some of that ventral vagal connected tone. So here's some tools for regulation integration. You can map window of tolerance with your clients during one of these states. And the window of tolerance is just our ideal nervous system level of arousal for learning and for being functional and happy in the world. And then there's somatic tracking. I really want to highlight this. Method of levels is a wonderful development based on perceptual control theory in the field of CBT. It's a wonderful way to observe and keep your clients in the moment. It's transdiagnostic. Someone with schizophrenia can still have method of levels applied in their psychiatric evaluations because it's asking questions about the present moment. So we'll talk a little bit about that. Heart rate variability. This is a variation in time between the heartbeat, and this is the measure of our parasympathetic nervous system activity, and you can't fake it. So it's a really great objective way to monitor. And it's important to just note that it varies per person. And higher HRV is usually associated with more stress adaptability, and lower HRV means you're more sympathetically dominated. So here's some output from a heart map, or a ring, rather. So a chart for HRV for your reference. These are HRV values that are typically reported in the research, but know that your R ring is going to have lower values than this because it uses RMSS measurements. These are the factors that can affect HRV. So this is the effect of cannabis on HRV, and I'll let you take a photo of this slide so we can make sure to get through everything. Again, not a lot of large controlled trials, as we know. And putting it all together, just a summary, the slide of everything that's been presented thus far. All right, cannabis to support expanded states. I think a lot of us have some familiarity with the ideas or ways to do this, but it does affect HRV. And then back to our case study. So what was happening in our talk, what was happening with the patient? This is a concept of phenomenon between nervous systems. There's many different ways to explain it. There's co-regulation or neuroception theories. There's mirror neuron and interoceptive resonance and physiologic synchrony, but the way I like to sum it up the best is biobehavioral synchrony. And this is a term coined by Ruth Feldman, where she empirically measured HRV, cortisol gains, and affect synchrony, and described what's this linking as biobehavioral. So it's significant because the clinician's nervous system becomes a co-regulating instrument, not just an observer in that psychedelic experience. Very important to do your due diligence, and if you feel comfortable, experience these medicines for yourself before you administer them, and get proper training in how to. So back to Freddie. We began ketamine IV induction for his state of freeze, 6 sessions over 2 to 3 weeks. He continued with ketamine-assisted therapy with lozenge and nasal spray, and attended the IM groups. We do intramuscular group work and have integration groups with the group as well after in the form of group therapy. We prescribed his medical cannabis, so we talked about how to be more intentional with that and to use strains or cultivars that would be useful for his state. He continued with his therapist and made progress. She noted more insight and somatic awareness. Blood pressure came up. More facial expression, laughter, reduced psychomotor retardation. And he had spiritual experiences. His mystical experience questionnaire was as high as 95. The client experienced what he calls, or they called, teenage girl puberty. I think that sums up what happens when you exit this free state. The feelings returned. So we brought attention and awareness to that and normalized it. And here's the impressive improvement on his Beck depression inventory. Look at that. After the ketamine induction, each vertical line represents a ketamine infusion. He at one point did not qualify as having depression by this measure. This slide also shows the importance of continuing therapy. Okay, this is an ongoing thing. We're managing this over time. Here are the key takeaways. Thank you so much for your attention today. I really appreciate your time. This is how you can keep up on what we're doing, learn more about our practice, collaborate. Thanks again.
I was gonna say, I don't know about you all, but Dr. Alavi's presentation, I definitely feel as if I'm in my ventral vagus state. So I'm very calm, I'm very relaxed, and I'm excited to continue the conversation discussing the intersection between cannabis, psychedelics, and other forms of integrative medicine.